Welcome back to the deep dive. We're here again, taking that big stack of sources, all the research, and boiling it down for you. Today, we're looking at a real survivor, a super common bacterium, very stealthy, that's figured out how to live somewhere truly hostile. We're talking about the human stomach, the most acidic place in the body. Okay, let's unpack this.
We are definitely diving deep into Helicobacter pylori. You probably know it as H. pylori. It's a bug that sets up shop right in the stomach lining, and that leads directly to chronic gastritis. What the sources show is pretty amazing, really. It's not just some random bacteria. It's incredibly adapted to get around our body's defenses.
Yeah, that survival strategy is exactly what we want to get into. So our mission today, figure out how it does this, how it actually spreads, because that's surprisingly broad, and what the paths are for diagnosis and hopefully getting rid of it. We want you to really understand this infection by the end.
Absolutely. And, that survival question starts with the stomach itself. We're talking a pH of maybe 1.5 to 3.5, just intensely acidic, designed to break things down, kill microbes, most bacteria, gone instantly. So yeah, the big question is, how on earth does H. pylori make a home there?
It seems almost impossible, doesn't it? Like you just assume nothing could live in that acid bath. What's the trick? What's its specialized defense?
Well, what's fascinating here is that H. pylori doesn't really try to neutralize the acid directly. It's more about location and movement. It avoids the worst of it. The sources are clear. It targets and colonizes the cells lining the stomach wall, the ones that secrete mucus.
Okay, but those cells are still pretty close to the action, aren't they? I mean, they have mucus protection, but that's our defense. How does the bacterium hijack that?
It uses these little whip-like appendages. They're called flagella. Think of them like tiny propellers or corkscrews. H. pylori uses these flagella to actively swim or drill right through that thick mucus. It embeds itself deep down in that layer right next to the cells.
Yeah.
And that mucus layer itself, it's much less acidic than the main stomach cavity. It's the perfect hiding spot.
Wow, okay, so it's not fighting the acid, it's basically hiding from it.
Yeah,
Using our own shield against us. That's pretty clever, like a microscopic submarine.
that's a great way to put it.
Yeah.
Exactly. And once it's settled in, that's when it starts causing that chronic inflammation, the gastritis we mentioned. But here's the really crucial part. Chronic inflammation isn't just uncomfortable. It's a starting point for much worse things. If we connect this to the bigger picture, long-term untreated H. pylori infection is a major risk factor for certain kinds of stomach cancer. We're talking gastric adenocarcinoma, multiple lymphoma. It shifts from just being an infection to a serious public health concern.
Okay, that definitely raises the stakes. It's not just about a stomach ache then, it's about potential long-term damage, even cancer. So now we know where it lives and how serious it can be. Let's talk about how it gets around. How does it spread from person to person? Because your notes suggest the roots are wider than many people think. Here's where it gets really interesting.
Yeah, this is key. We often think of infections like this maybe coming from bad water or food, but H. pylori, it's overwhelmingly spread through person-to-person contact. And the ways it can spread are, well, quite diverse. It's not just one simple pathway. We're looking at about 4 main routes.
Right, let's list those out clearly. What are they?
Okay, so we have the fecal-oral route, which is common for gut bugs.
Mm-hmm.
Then there's gastric-oral think, like through vomit, unfortunately. And then the two that often surprise people, oral transmission and potentially even sexual routes.
Oral, that's huge, isn't it? That implies everyday things, kissing, maybe sharing drinks or utensils, just close contact over time with someone who has it.
It does. And that really highlights why it's so widespread and, frankly, hard to control completely.
Yeah.
Someone can carry it without symptoms, many people do, and unknowingly pass it on within a household, for instance. And this ease of spread gets amplified by specific risk factors your research pulled out.
Okay, let's go through those. What makes someone more likely to pick up H. pylori or have it stick around?
Well, they kind of fall into a few buckets. First, there are behaviors, things like smoking, maybe heavy alcohol use, seem to increase susceptibility. Second, environment and living situations play a big role. Close contact with someone already infected is a clear risk.
Right.
And then poor sanitation or crowded living conditions. These make transmission, especially that fecal-oral route, much more likely.
Right, makes sense. And there was a third category too, wasn't there? Something about family?
Correct. A family history of H. pylori is also a risk factor. That could be ongoing shared exposure in the household, or maybe even some genetic predisposition. We see it run in families. Understanding all these routes and risks really explains why so many people globally actually have this infection.
So if you're experiencing some of those persistent symptoms, that nagging abdominal pain, maybe nausea, weight loss you can't explain, and maybe some of those risk factors apply to you, How does a doctor actually confirm it is H. pylori causing the trouble?
Yeah, that's critical because the symptoms, like you said, stomach pain, nausea, vomiting, sometimes even ulcers or seeing blood in the stool, they can overlap with lots of other GI problems. So accurate testing is really essential. We generally divide the diagnostic methods into two main types, non-invasive and invasive.
Okay, let's start with non-invasive, the easier ones, presumably.
Right, these are tests that don't require going inside the stomach with a scope. We can look for H. pylori antigens, basically bacterial proteins, in stool samples. We can sometimes detect it in oral samples too. But the real star of non-invasive testing is the urea breath test, the UBT.
Ah, the breath test. How does that one work? It sounds kind of neat.
It is pretty clever. It relies on something unique H. pylori does. This bacteria produces a large amount of an enzyme called urease. So for the test, you swallow a special liquid or capsule containing urea that's been tagged with a harmless isotope, usually carbon-13. If H. pylori is present in your stomach, its urease enzyme breaks down that tagged urea. This releases the tagged carbon as carbon dioxide, which gets absorbed into your bloodstream, and then you breathe it out. We collect your breath samples before and after you take the urea, measure the tagged CO2, and if there's a significant increase, boom, H. pylori is there.
That's fascinating, detecting the bacteria's activity by its exhaust fumes, basically. So when would a doctor need to move beyond these non-invasive tests to the more invasive ones?
Typically, you'd move to invasive methods if the non-invasive tests aren't clear, or, more importantly, if the symptoms are really severe or concerning. Things like cystected ulcers, significant bleeding, like those bloody stools you mentioned. Or if there's a worry about something more serious, like the potential for malignancy, that cancer risk we talked about earlier.
Got it. So in those more serious situations, what do the invasive tests involve?
Invasive testing means doing an endoscopy. A thin tube with a camera goes down into the stomach to take a direct look. And crucially, during the endoscopy, the doctor can take small tissue samples, biopsies, from the stomach lining. With those tissue samples, they can do several things. They can try to culture the bacteria directly, though that can be tricky. They can do a rapid urease test right on the biopsy tissue itself. It works on the same principle as the breath test. Or, and this is very common, they send the tissue for histopathology. That means a pathologist looks at it under a microscope to actually see the bacteria and assess the degree of inflammation or damage to the stomach lining.
Okay, so a whole range of tools, from breath tests to biopsies, to really nail down the diagnosis and see what kind of impact it's having. Now, once H. pylori is confirmed, we get to treatment, eradication. Given how well it hides in that mucus bunker, just taking one type of antibiotic probably isn't going to cut it, right? It seems hard to reach.
You're absolutely right. It's a stubborn infection because of where it lives.
Mhm.
That's why the standard treatment isn't simple. It's quite specific and pretty intensive. It's a 14-day combination therapy, usually involving multiple drugs taken together for the full 2 weeks.
Combination therapy, okay. And that typically involves antibiotics plural plus something called a proton pump inhibitor, a PPI. Now, this is the bit that sometimes seems counterintuitive. If the bacteria is hiding from the acid, why give a PPI, a drug that reduces stomach acid? How does making the stomach less acidic help kill the bacteria?
That is an excellent question, and it's a really important part of the treatment strategy. Your sources explain this well. Even though H. pylori hides in the mucus to avoid the harshest acid, the overall acidic environment still influences things. Reducing the acid with PPIs actually helps the antibiotics work better in a couple of key ways.
Okay, what are those ways?
First, many antibiotics are less stable or less effective in a highly acidic environment. By reducing the acid with a PPI, the antibiotics can survive longer and reach higher, more effective concentrations right there in the mucus layer where the H. pylori is located. Second, making the environment less acidic might slightly alter the consistency or thickness of the mucus layer itself, potentially making it a bit easier for the antibiotics to penetrate and reach the bacteria hiding within. It also helps heal the inflamed stomach lining.
Ah, I see. So the PPI isn't directly killing the bacteria. It's creating better conditions for the antibiotics to do their job effectively. It's like prepping the battlefield.
Precisely. You're improving the efficacy and delivery of the actual bacteria-killing drugs.
Makes sense. But 14 days of multiple drugs, that sounds like it could be tough for people to stick with. How crucial is finishing the whole course?
It's incredibly crucial. Compliance is key. When patients follow the full 14-day regimen correctly, the eradication rates are actually very good, often well over 85%, sometimes higher depending on the specific drug combo. But you're right, it's an intense regimen. Multiple pills, maybe twice a day. If someone stops early because they feel better or misses doses, that's how antibiotic resistance develops. And if resistance occurs, the H. pylori becomes much harder to treat with future attempts. Finishing the course is absolutely vital.
Right. Okay, so let's recap this deep dive. We've covered the mechanics that clever flagella-driven hiding in the mucus and the serious long-term risks like gastritis and cancer. We talked about the surprisingly varied ways it spreads fecal, gastric, oral, even sexual routes. We looked at symptoms and the diagnostic tools, from the smart urea breath test to invasive biopsies. And finally, the treatment. That specific 14-day combination of antibiotics and PPIs designed to overcome the bacteria's defenses and the absolute need for compliance. So what does this all mean? What's the big takeaway here?
If we connect this to the bigger picture, I think the major takeaway is how interconnected our health is, especially regarding infections. Knowing the transmission routes, particularly the person-to-person ones like oral, and the risk factors like close contact and living conditions, is really fundamental. It underscores that gut health isn't solely about what you eat. It's also significantly influenced by infectious agents and our interactions with others. It's a wider perspective than we often take.
Yeah, it really challenges that simple view. This one tiny bacterium shows how things like close relationships, living situations, basic hygiene, they all play a direct role in the health of our stomach, maybe more than we typically think.
Exactly. And that leads to something to maybe mull over. Consider this. Given these diverse person-to-person transmission routes we've discussed, including oral and potentially sexual contact, how does really understanding this tricky bacterium change how you think about preventing infections and maintaining gut health, especially in shared environments like homes or even intimate relationships? How might you think about your own risk or your family's without necessarily jumping straight to testing? Just something provocative to consider until our next deep